I would like to introduce our speaker today here. So Dr. Gabrielle Rozio is a licensed psychologist practicing in Scottsdale, Arizona. She earned her doctorate and master's in clinical psychology from Midwestern University. She has also completed a master's in counseling at Arizona State University. Dr. Rozio provides individual and couples counseling and has specialized training in treating OCD. Other areas of focus include anxiety, depression, relationship issues, life transitions, self-esteem, and stress. She employs cognitive behavioral, mindfulness-based, and client-centered methodologies. Her evidence-based, collaborative, and personalized approach is designed to support individuals and couples in building the life they want to live. So without further ado, I know we're all muted, but if you can, I'm going to trust that you're doing it along with me. We're going to go ahead and give a big old round of applause for our speaker and let her take it away. Welcome. There's 3 claps in this room, so I hope you heard all of them.
Thank you, Jordan. I appreciate that. And thank you so much for the introduction. Hi, everyone. Dr. Rozio here. I am very excited to chat with you all today about OCD through some of the training that I've done and just experience in working with individuals who experience OCD. I've kind of developed a really big soft spot for clients who are struggling with obsessive compulsive disorder. So I'm really excited just to talk with you about some evidence-based treatment, clinical applications, and really what OCD is all about. And hopefully that will be helpful for those of you that are working with these clients. So we'll start with just an overview about what we'll be doing today. So the learning objectives, like were included in the flyer. We'll start with developing an accurate understanding of OCD, how it develops and how it's maintained. And the reason why I want to start with that is because that really helps us understand the rationale for exposure and response prevention. So it's very important that we have an accurate understanding of OCD. And then we'll talk about the differences between OCD, generalized anxiety disorder, and obsessive compulsive personality disorder. In my work with clients, this is often a question that comes up. So clients are often curious, well, do I really have OCD? I really just think I'm anxious. Is it possible that, it's just my personality type? So I really think it's important that we understand the difference, that we can help clients navigate these questions when they bring them up to us. And then we're going to talk about some common myths about intrusive thoughts. And this is really important as well, because what I've learned and what we understand is that individuals who experience OCD often present with a cluster of ideas or ways of thinking about their intrusive thoughts that are myths. And so when we bust them, it really helps them change their relationship with their thoughts and really helps them improve and achieve the quality of life that they're looking for. And then we'll jump into ERP, what that looks like, and then we'll even go over some clinical applications of some work that I've done with clients. So that's kind of our roadmap for today. Before we do all that, I really want to just take a minute to acknowledge the functional impairment that's associated with OCD. And I've heard, and I'm sure all of you have heard, some terminology or some kind of conversation around what OCD is, or, it's just about hand washing and that's not that big of a deal. And I just want to make sure that the message that we're sending today is that OCD goes way beyond hand washing. And so one particular study that looked at the functional impairment associated with OCD broke up domains of life. So we have home management, work, relationships, and social life, and took an assessment of how each of these areas were impaired in individuals' lives who had OCD. So I found these statistics just really powerful. So in their study, for individuals who met criteria for OCD over the last 12 months, 78% of those individuals reported that they have severe or moderate impairment in these domains. And that's a really big number, right? That means that 78% of people are struggling severely and moderately. We're not including those individuals who had mild impairment in those areas. And then another statistic that really stood out to me was that those individuals who met criteria for OCD identified 45 days out of the last year where they indicated that they were completely, totally unable to carry out work or normal daily activities. 45 days is a lot. And when we're talking about potentially 45 work days or 45 days where we're not able to care for our families, 45 days where we're not able to care for ourselves, it's a lot of time. And so I want us all to have this frame of reference that there is functional impairment that goes beyond even what we might be able to see, right? We may be able to see some compulsions, but we can't see all of them. And we certainly can't see the impact that it has in all of these domains of people's lives unless they share it with us. So I want to make sure that we're recognizing that before we jump in to some of the content. So now, what is an individual with OCD experiencing? So this is some of the diagnostic criteria from the DSM, and the obsessions are defined as recurrent and persistent thoughts, images, or impulses that are experienced as unpleasant and unwanted and cause distress or anxiety. And then the second part of that is that the individual who experiences obsessions attempts to ignore, suppress, or neutralize the distress associated with them. And so for our conversation today, I generally refer to obsessions as intrusive thoughts and images. And the reason why we do that is because, much like it sounds, these thoughts and images really do intrude on an individual's natural flow of thinking. These obsessions, as we understand them, really come out of nowhere and really just pop into our heads. And so that's why I refer to them as intrusive. Then we have compulsions, which are defined as repetitive behaviors or mental acts that the person feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So if we're talking about compulsions, again, a compulsion may look like hand washing. There are other types of behaviors that qualify as compulsions that must be followed according to a rigid set of rules. So let's say, for an example, an individual develops a ritual where they have to kiss their partner on the cheek 3 times before they leave. That is a very specific ritual that has to be applied in a specific way. And if they're not able to do that ritual, kiss their partner on the cheek 3 times before they walk out the door, that also can become distressing. And then the motivation behind the compulsions is that they're aimed to reduce or neutralize the distress. And so it's very important too, as we talk about, we'll talk about later in the presentation, that we understand that when an individual is engaging in a behavior that's designed to reduce distress, that is what qualifies it as a compulsion. So whereas I may search on Google because I'm really interested in some pots and pans that I want to buy, an individual who researches pots and pans because they're very worried about buying the wrong pots and pans, because if they buy the wrong ones, they may get their family sick and their family members might die, that would qualify more as a compulsion because the motivation there is to reduce distress and respond to an obsession that they have about harming their family. Now, another caveat about compulsions is that oftentimes, not all the time, but oftentimes, the behaviors or the mental acts that the individual is performing are not always connected in a realistic way with what they're designed to neutralize or prevent. So in that example that I shared with the individual who feels that they, has this urge and drive to kiss their partner on the cheek 3 times before they leave for work. If the reason why they're doing that is because they have an obsession about or an intrusive thought related to their partner getting into an accident on their way to work, kissing their partner on the cheek 3 times really isn't connected in a realistic way to preventing them from getting in an accident, right? So it's understanding that component of compulsions as well, okay? So now we're gonna unpack a little bit more some common obsessions. So what we know is that there are generally themes related to the obsessions that individuals present with. And these are only some of the themes. This is not an exhaustive list, but these are the ones that are pretty common that we see often. And again, another kind of little caveat here is that an individual may present with obsessions from several of these areas. And with the clients that I work with, oftentimes we see several themes to their obsessions. So what does an obsession look like or sound like related to any of these categories? When we're talking about an intrusive thought, the thoughts generally take the form of a what if statement. In that way, the thought sets the stage for the client to question or doubt whatever comes after the what if. So if we're talking about contamination, in this situation, oftentimes the individual has a fear of coming into contact with contaminated substances. And these substances are often bodily fluids, germs, household chemicals, dirt, right? So the individual is very fearful, might experience a lot of distress if they're required to come in contact with germs or household chemicals. And the thought that they might have is, what if these household chemicals cause my parents to die? What if my child eats this dirt and they get sick? So oftentimes the intrusive thought is phrased as a what if statement. And the reason why they're afraid of these contaminated substances is usually driven by a feared consequence. So in this, right, in the few examples that I gave, oftentimes contamination is related to potentially people that they care about being harmed. If we're talking about an image may be the vision of their child eating the dirt, or the image of their child becoming sick, right? That might be what an intrusive image looks like. If we're talking about religion, oftentimes we see individuals who present with excessive concern, specifically with regarding offending God. So whoever their higher power is, or whatever God they believe in, right? So the individual may be sitting in church and all of a sudden experience an intrusive thought that popped right into their head that sounds something like, what if I don't really believe in God? Or what if I just rip up this Bible right now? What would happen? And so those thoughts, again, set the stage for the client to question or doubt themselves and what they're doing. So a follow-up thought might be, I just had this thought while I'm sitting in church. Why am I thinking this thought? Why would I wonder what it would be like to rip up this Bible, right? So then we start to question, am I really as devout as I believe I am? Am I really as honorable and moral as I think I am? Again, all of these what if questions lead to the individual doubting or questioning themselves. And then we have obsessions surrounding identity. So specifically what we see here is that an individual with OCD may experience intrusive thoughts or images related to their sexual orientation or their gender identity. So an individual may be married, has chosen how they identify, and all things considered, they feel comfortable with who they are. And then all of a sudden they experience an intrusive thought. What if I'm really not gay? What if I'm really not attracted to my spouse? What if I really don't identify as female, right? So those types of thoughts, again, set the stage for the individual to question or doubt themselves because of the fact that they even had the question in the first place. And then we have sexual thoughts. And oftentimes sexual thoughts are some of the most distressing and uncomfortable for clients to share with us. So it is really important that we create a safe space for them to do so. Sexual thoughts often involve thinking about or visualizing the individual engaging in sexual relations, maybe with relatives or with children. And so those thoughts, again, start to make us wonder, why am I thinking these thoughts? And then the fear based on those thoughts is, what happens if I actually act on those thoughts at one point? Why am I having them? What does it mean about me? What if I am attracted to a child, right? So all of those different forms of intrusive thoughts get the person to really start to be concerned about themselves. And then we have harm thoughts. Those harm thoughts can be related to self or to others. So an example might be a parent might say, I'm afraid to pick up my baby because what if I drop them, right? The what if I drop them suggests that the person isn't sure that they won't. And so because of that, they experience worry, and then they may choose not to pick up their child. Other forms of hard thoughts might be related to accidental harm. So what if I accidentally run over somebody while I'm driving? Or they can be intentional. And a lot of times I've experienced they can be graphic and violent. So an individual might have an image in their head of killing or stabbing their family members. And so again, those can also be alarming for the individual. And then we have another kind of category of obsessions that we refer to as just right. And sometimes it's even referred to as just right OCD. So in this situation, the individual experiences a sense of discomfort when whatever it is that they're worried about or thoughts that they're having or obsessions, that the thing doesn't feel or look just right. So a specific example that I have from a client that I worked with is the individual felt that the towels throughout their house had to be folded in a certain way. They had to be folded in their mind just right. And there wasn't in this situation a feared consequence. They didn't say, if I don't fold the towels just right, something bad will happen to me or to my loved ones. It was more of a sensation that they experienced in their body. And when we talked about it in session, it was more of like a tension or a restlessness that they experienced where it's like, oh, it's not right unless I fold the towels in a certain way. And so in response to that, they often would jump up and fix the towels. So those are just some common themes of obsessions that we often see. And then again, if we take it one step further and start to think about the other qualification of obsessions is that the thoughts are experienced as unpleasant and unwanted, right? That's part of the criteria in the DSM. And maybe after hearing some of these examples, I'm hoping it's not as surprising to see why these thoughts are experienced as unpleasant and unwanted, because what we often find is that these thoughts go against the person's values and the person's wishes and the way the person wishes to be perceived. And that is one of the main reasons why the thoughts cause distress. So the individual who identifies as religious and moral and as responsible and ethical doesn't want to envision themselves ripping up a Bible. The individual who cares about their family and loves them so much doesn't want to think about, right? It's hard for them to sit with the idea of potentially dropping their child. And because that goes against everything that they want to be, right? A good and loving and caring parent, having these thoughts is very unpleasant. And they would really wish to not experience them again. So those are just kind of some tidbits and points related to obsessions that I think are important to consider. So now, having had a little introduction to some intrusive thoughts, images, and impulses, we are going to do a little bit of true and false. So I'm going to read each of these statements, and then what I'm going to have you all do is jump into the chat and put your answers in. So we'll do them one at a time, and then I'm going to defer to Jordan to help me read the responses in the chat because I can't see them. Okay.
And I've got the chat open.
Okay, chat open. The first one that we're going to do is thoughts, images, and urges have nothing to do with our character. And I'd like you all to enter whether or not you believe that statement is true or that statement is false.
Ooh, I am seeing a lot of trues, an occasional false, but I'd say general consensus here is true.
Okay, so should I reveal the answer? Do we have enough? Did everyone have a chance to participate that wants to?
Probably have a solid 100 answers here.
Okay,
I'd say a lot of trues.
Okay. Yes, exactly. Thoughts and images and urges have nothing to do with our character. So this is something that individuals with OCD often struggle with. So the common myth that individuals with OCD have is this idea that their thoughts speak to their character or some underlying intention that they have. So I have had several clients come into my office and say, well, I'm having this thought, and maybe it means that some part of me really wants to do this, or this is a part of me that's trying to find its way out. And it's this dark side that I have maybe, or if I'm having this thought, then maybe this means that this is the type of person I really am, right? So all of those ideas are essentially myths, right? Thoughts, images, and urges have nothing to do with our character, because what we know, and which is a lot of these myths I work with clients in session to kind of bust, is that our character relates to what we actually choose to do or choose not to do, right? We might have a thought about harming our family or stabbing our family members. In our behavioral choices, we oftentimes don't choose to engage in that behavior, right? So that is more reflective of our character. Thoughts just happen. They're not necessarily thoughts that we've intentionally tried to create and design and will. So we oftentimes talk about that myth. So let's try the next one. Thoughts and images can change probabilities in the real world. I'll give everyone a minute to.
Oh, answers are flooding in. I'm seeing a lot of false, an occasional true, a couple trues, but a lot of false.
Okay, let's give it another couple seconds to let people jump in.
Got it. Going once, going twice. Well,
all right.
Computer issues and false. I'd say false is the consensus.
Yes. Okay, perfect. False. So thoughts and images can change probabilities in the real world. Again, individuals with OCD, again, part of this kind of cognitive framework, the way individuals with OCD often relate to and think about their thoughts is that they believe that their thoughts and images can change probabilities. And what we refer to this concept as is this idea of thought action fusion or magical thinking. So an individual might think that if I continue to have thoughts about having sexual relations with a child, that is going to make me more likely to do so. Or if I think about my partner getting into an accident on the way to work, because I'm thinking about it, it makes it more likely that that's going to happen. And so because that is their frame of reference, the frequency of which they experience these thoughts also increases their distress. And this idea that they need to essentially engage in a compulsion to ensure that their feared outcomes don't occur. Essentially, what we know is that thoughts and images really have no power, and they have, in and of themselves, have no effect on the world unless we choose to engage in a behavior. Okay? So then the next one, every thought is worth thinking about. I will give everyone some time to answer that one.
All righty, answers are coming in. I think they're getting ready for these questions now. They're thinking ahead of time. They're putting them in real quick. I did get a couple that just said fake. I really enjoy that answer. I'm seeing a lot of false though. So far as a very strong majority is false.
Okay. Nice job for those of you who said false. Yes, every thought is not worth thinking about. And again, individuals with OCD very much feel that all of their thoughts are worth thinking about. And so one of the ways that I kind of explain this or talk about this is it's kind of talking about a metaphor to a radio station, right? So let's say there's, 10, 20 channels on the radio station. We get to choose which one we listen to. Sometimes when you're driving through an area that has not a lot of service or connection, it's sometimes when you're turning or tuning to a certain station, it sounds like two radio stations are kind of overlapping each other. And that's very annoying, right? When you're driving on a long drive and you just want to listen to something interesting, but there's a lot of background noise and overlapping conversation. So in those moments, we would probably try to tune out the background noise and tune out the conversation that's annoying and only focus on the channel or the part of the channel that seems interesting to us. And so I make that parallel to what goes on in our mind. So all of our minds are essentially filled up with some junk stations. There's some stations in our mind that we really don't necessarily need to grant as much meaning to. We can just allow them to be there in the background and tune them out. And so that is one of the ways that I explain this concept to an individual who very much feels that if they're having a thought, it's worth thinking about, worth giving attention to, worth exploring, figuring out where it came from, what it says or means about them. And so through kind of talking it through and using some metaphors and exploring some of these myths, we're able to help them change the way that they relate to their thoughts. And then the last one. So our thoughts are not under our control. Let's have everyone put in their answers for that one. Ready, set, go.
Oh, they're coming. Oh, I saw. All right, I'm seeing some true, seeing some falses. I'm also seeing both true and false. There's a couple of those that have come through. Both. This is a very divided one.
Okay.
I'd say so far we're about 50-50.
Okay. Interesting. Okay.
Yeah.
Dun, dun, dun.
Dun, dun, dun.
Dun, dun, dun. Let's see. So the answer is true. And so let's talk about this one a little bit more. So what we know, what researchers now understand and believe to be the case is that most of our thoughts are not under our conscious control. So I'll let that sink in for a minute. Researchers now believe that most of our thoughts are not under our conscious control. And so it's very important when we're talking to individuals who experience OCD, who believe and who relate to their thoughts in such a way that they try to control them. They try to will them not to be there. They try to distract themselves. They try to think about something else. They try to refute the thought. So they may have an intrusive thought of, what if I drop my baby? And then immediately thereafter have another thought that sounds something like, you would never do that. Or don't think about that. Think about something else, right? All of those responses or attempts to control their thoughts have generally been found for them ineffective. And so what we know is that there are certain thoughts that we can intentionally and willfully create. So if I ask you to think about your favorite color and to tell me the answer, right? You're intentionally thinking about that thought and you're coming up with your favorite color. If I ask you to tell me what 1 + 1 is, I'm inviting you to intentionally think about that. However, our intrusive thoughts and images and urges, and frankly, some other thoughts that we have that we might not even qualify as intrusive, can and do just pop into our head. And sometimes we really like that. Sometimes we appreciate that. So let's take it, for example, an artist, a musician, or a painter may say that while they're sitting there looking at their canvas or while they're in the studio, all of a sudden an idea pops into their head. We might call that an intrusive thought or idea or image. It just popped out of nowhere and came to them while they were driving, while they were sitting at the studio. And so in that way, we actually kind of like having some intrusive thoughts sometimes. And those two aren't under our conscious control. So busting this myth may be one of the most powerful ones for working with individuals with OCD, because a lot of the time, the messages that they have received or the messages that they send themselves is that they should be able to control these thoughts. They should be able to make them go away. They should be able to combat them, minimize them, ignore them, and suppress them. And what they find is that it just doesn't work. So, and we'll come back to that when we talk a little bit about treatment as well. So thank you guys for playing true or false. And let's continue on to compulsions. So We'll talk a little bit about some of the common compulsions. And so I broke them up into two categories. We have covert and overt compulsions. So if we're talking about what normally comes to mind, if we're thinking about OCD, might be the hand washing, the ordering, the checking, and the collecting. Those are behaviors that we can see and that are obvious. We also have covert compulsions, which are a little bit sneakier, harder to detect, even within the individual themselves. So oftentimes when I'm working with an individual and we're, doing an intake assessment, or we're really doing a deep dive into their self-monitoring and their tracking their intrusive thoughts and their rituals, oftentimes they have a hard time recognizing or identifying that these covert behaviors actually qualify as compulsions. So I'll just talk about a few from some examples that I've had with clients. So for reassurance seeking, oftentimes this looks like checking in with somebody in our environment about something that we're worried about. So an example that I have is in a client who had obsessions related to contamination. They themselves would often engage in checking. So they would smell around the house or smell items, smell clothing, to check if there was bleach on them or if there was gas on the items or on the clothes. What they would also do is, because they weren't sure of their own abilities to detect and to smell, they would then turn to their partner or to some other adult in the home and ask them to check and to smell for them. Can you smell this and make sure that you don't smell bleach? Or I smell bleach, do you also smell bleach? In that sense, they're experiencing the obsession. What if there's bleach on this item? And the ritual there is having the other person confirm that there's no bleach so that their distress is reduced. Another one that's very common is counting. And again, this is another one that really can happen privately. And so when we're doing an intake and when we're exploring these things, it's also important to ask about them. I had a client who counted all of her items before they left the house, before they left a public place, to ensure that they had all of their things. They counted, multiple times, because after counting the first time, they then had an intrusive thought or worry of, what if I missed something? What if I miscounted? What if I forgot something? And so if we think about it, like counting your things one time maybe takes like 5 seconds. But what we know and what I've experienced is that we oftentimes have to repeat the compulsion, or we have to engage in the compulsion for a longer period of time to experience the relief that we're looking for. So during this client's experience, while we were tracking their intrusive thoughts and the rituals they were engaging in and how long those rituals were taking them to complete, there were times that the counting took 5 minutes, and there were times that the counting took 25 minutes because of the repeated counting. So these are just some general ideas to give you guys a reference of what compulsions can look like. And now we're going to transition to talking about the differences between OCD and GAD. So the way, I know you guys can read. So the way I'm going to kind of talk about this and explain it is by using a scenario, using an example. So an individual who experiences generalized anxiety disorder oftentimes has worries about multiple areas of life. So let's say there's an individual who's worried about how their divorce is going to settle out, who's worried about if they're going to get this new job that they're applying for. They may be worried about how their kids are doing in school, right? So there's general worry about a variety of areas of their life. And usually this worry is a train of thought that attempts to solve problems. So for this individual, they may be thinking, okay, what can I do to increase the likelihood that I'll get this job, or to make me more marketable? Or how can I prepare better for this interview so that I increase my chances that I'll do well and I'll outperform the other applicants. And because of that, they really experience these worries as appropriate, even if they may be able to admit, maybe I'm a little bit too worried about getting this job because I know there are other jobs out there. maybe I can admit that my worry about how my kids are doing in school is excessive. It is perceived as appropriate because it goes along with their values and it makes sense. And they really do want to get this job because let's say, for this made up scenario, this person has been in school for years, and this is one of the first jobs they're applying for after school. And it makes sense that they're motivated to get it. They've worked really hard. It's a really tough job market. And so the worry may be excessive, but also may be appropriate for the field that they're going into. And so these individuals don't resist or suppress their worries. Again, because they're perceived as appropriate, there really isn't as much distress. And then for them, when the stressor is removed, the distress lessens. So once the person finds out whether or not they got the job, or they have a parent-teacher conference and they find out how their kid's doing in school, the distress lessens. On the flip side, an individual with OCD usually, like we've talked about, their obsessions usually surround a specific theme. And the specific theme is related to a feared consequence. So in this example, an individual might say, what if, right? That what if I don't get this job? And then the follow-up thought might be, I'll be broke, my spouse will leave me, and I'll be alone forever. So the doubt is related to then a very specific feared consequence. And because the individual doesn't want to be alone forever and doesn't want their wife to leave them, these thoughts are perceived as bothersome and unwanted. And because they're bothersome and unwanted, they attempt to suppress them or to replace them. So the individual might say, well, I'll try not to think about that. Or I'm sure that my wife really loves me and that she won't leave me. Or I'm going to engage in these behaviors to reduce my distress and hopefully assure that my wife won't leave me. And so again, they're engaging in these rituals to attempt to control or eliminate their distress. If I check in with my wife every day to make sure that she loves me, that will make me feel better, right? And again, the key difference here is that the individual who's experiencing these thoughts perceives them as going against their values or their self-perception. And so that is one of the main reasons why they're so bothered by them and why they are so strongly motivated to attempt to eliminate or control or replace the thoughts. Okay, so that is how we can work to identify the difference if we're working with an individual who's coming to our office. Oftentimes I've experienced clients coming to me just saying they're anxious and they're really worried and they're really stressed. And once I start to unpack and start to explore with them, I'm able to differentiate whether it's generalized anxiety or whether or not they're engaging in behaviors that are motivated to reduce distress that may be illogical or irrational. And that way I'm able to recognize the OCD. And then we have OCD versus OCPD. And again, I think this is important for a number of reasons, but one of the main ones is just the similarities in the name. And I think it's important that we recognize the difference so we can identify it in our clients when we're working with them. When we're talking about obsessive compulsive personality disorder, I'll use another example for this one. Clearly, I love examples. I'll use an example of an individual who color codes their closet. So that if an individual has obsessive compulsive personality disorder, they color code their closets. They find this ritual or this perfectionism to be valuable to them. They feel that this is the right and the best way to organize their closet. There is even this sense that others around them should also be acting this way. Why isn't everybody color coding their closet? It's just the most efficient, because that way, when I want a red shirt, I know exactly where to go to find it, and it's so much easier, right? So they perceive these behaviors as appropriate and as making sense, and that everybody else has it wrong. And then they're also very rigid in applying these behaviors. So because of that, there really isn't any distress There really isn't any fear and there really isn't any resistance. If somebody walks into their closet and the red shirt is next to the yellow shirts, if anything, they'll probably just be really annoyed or irritated that somebody didn't color code the way they were supposed to, right? And so when this individual seeks therapy, it's often due to conflict or difficulty in an interpersonal domain, a social domain, or an occupational domain. So oftentimes they may be referred by somebody else. They may say, so-and-so says I need to go to therapy. And that makes sense, right? If an individual is really, truly rigid and believes things should be a certain way because it makes the most sense and everybody should be acting that same way, I imagine that it would be hard, right, for them to collaborate with coworkers on a project or to move in with a partner and to share space or to engage in social plans with others who may view and do things differently. So we have some barriers in those domains in that way. Versus an individual with OCD experiences their intrusive thoughts and images as ridiculous and crazy. And I kid you not, almost every single person that's come into my office that has OCD has shared and have referred to themselves as ridiculous, crazy, illogical. I know this makes no sense, because their intrusive thoughts when they're able to think rationally and they're not in the midst of having the intrusive thought, they're able to say to themselves, this makes no sense. This is absolutely silly. When I tell myself that, or when I engage in color coding my closet because that makes me feel better and reduces my distress about dropping my toddler, I think to myself, how did I get here? Right? And so usually the individuals recognize that. And they do come to therapy on their own. They usually get to a point, right? And I think I don't remember how long it is, but usually an individual with OCD oftentimes doesn't seek treatment right away, right? The individual tries to manage and cope with their intrusive thoughts on their own. But when they do come to therapy, it's usually on their own, because they get to the point where they are like, how on earth can I continue living like this, right? And again, that difference is that the individual with OCD recognizes to some degree that the color coding is motivated by a desire to eliminate or to reduce distress. They are very fearful of their feared consequence, whatever that might be, depending on their obsession theme. And so they come to therapy because they really just want help and they want to understand how they can relate to their thoughts differently. And like we've talked about, there are times where the individual is hesitant to share certain thoughts and urges with others because of the themes and because of how they anticipate others may view them. So that is my my spiel on the difference between OCD and OCPD. And now we're going to transition into one of the next objectives, which is understanding how OCD develops. So what we normally find, like we've talked about, is that intrusive thoughts just come out of nowhere. And I do also want to share that we know that intrusive thoughts are rather common. One study that was done found that 90% of individuals identified or acknowledged that they've experienced an intrusive thought at some point in their life, right? We can't control our thoughts. Some things just pop into our head. And a lot of the times we just experience them as weird or bizarre. A lot of times our intrusive thoughts are funny. A lot of times they're helpful, right? So the intrusive thoughts in and of themselves are kind of a universal experience. However, individuals with OCD have responded to certain intrusive thoughts with fear and distress. Whereas I might imagine, I might also have a similar intrusive thought of, oh my gosh, what if I drop my dog, or what if I drop my toddler? And I might say, oh gosh, that wouldn't be good. My level of distress and fear related to that thought might be different. So what we see here is that Once the intrusive thought has been paired with fear or distress, a pathway forms from fear to the thought. And so in our brain, and specifically, and I want to make sure not to get too technical, but if we're talking about our fear structure, which is the amygdala, our amygdala learns as a result of experience. So once the intrusive thought and a fear has been paired together so many times, the brain associates those two together. And that every time the person experiences the intrusive thought and they then have distress, the brain learns to respond to certain stimuli with fear. And like again, when that pathway is triggered repeatedly, at a certain point, the individual experiences the anxiousness and the distress almost automatically to the thought because it has become so conditioned. And so that is just kind of like the starting point of how someone might develop OCD. An individual maybe is playing with their little sister and they're playing at the park or they're playing at home, and all of a sudden they get an intrusive thought about being sexually attracted to them. They experience fear or distress in response to that. And so this pathway from thought to fear is established. And then the next time they experience that intrusive thought when they're playing with their sister, they also experience fear and distress. And so that pathway just becomes intensified over time. And so one of the ways that I explain this to clients is using the metaphor of an alarm system. So for an individual who experiences distress, when they're experiencing OCD related to having sexual thoughts, may have an alarm system, right? If we're talking like a home alarm system, their alarm system is maybe a little bit oversensitive. So generally speaking, if you have an alarm system in your home, the system is coded, right? There's a code that the alarm goes off when someone opens the door, when someone opens a window, and maybe even when the garage door opens. And so that's generally speaking what would be the cause for alarm. With an individual who has experienced unwanted intrusive thoughts and impaired them with fear, their amygdala has learned to become fearful to many more things. So their alarm system goes off anytime a bird lands on the house or anytime a leaf brushes against the house, when objectively, there really is no danger to a bird landing on your house. I mean, it's maybe annoying, and maybe when, a bunch of leaves end up in your backyard, that's annoying, but it's not necessarily dangerous. So this is one of the ways that I explain how OCD has developed in the brain, that it's really just too many codes possibly are over-coded so that their body's alarm system is going off to way more things than it needs to be going off to. And so we also use that to talk about how to recode in treatment, which we'll get to in a little bit. So now what happens once OCD is developed? How is it maintained? Taking it one step further, right? So the first part of this cycle, the obsessions and then the anxiety and distress, is reflected in the last slide that we just went over. But now the individual is experiencing so much distress, disgust, maybe shame, guilt about their intrusive thoughts. It's really, really uncomfortable. And I don't know about you, but I don't like to be uncomfortable. I don't particularly enjoy sitting in anxiousness and restlessness. And I don't blame people for not wanting to feel that way. So, using their own intuition, using their ideas on what might make sense to help them navigate the distress they're experiencing, an individual with OCD engages in a compulsion or a ritual. And again, these compulsions and rituals may be one of those ones that we listed on one of the first slides. They can be really anything, but the intent behind the ritual is that the individual is trying to ignore or avoid or fight against the distress. And so when they do that, when an individual engages in a compulsion, they experience an immediate reduction in their anxiety. The individual who checks in with their spouse to make sure that there's no bleach, spouse says, "I don't smell any bleach, you're good." It's like, I'm good, I'm safe for now, right? It's instant and it's short term. However, that compulsion, the engaging of the behavior that provides short-term distress, negatively reinforces the intrusive thoughts and the compulsions, because we're more likely to want to engage in that behavior the next time we have distress because it felt really nice for the anxiety to go away. What happens is the individual never gets to experience what might happen if they didn't ritualize. In this process, they don't ever get to find out how long the distress will last, if the distress will decrease. All they know, right, is that they tried to get it to go away really quickly because it was uncomfortable. The compulsion worked. And so they keep doing that. So the next time they get an intrusive thought, they're like, oh yeah, that worked. I'm going to do that. What we know and what we found out through the research is that the very effort to fight and ignore and suppress our thoughts is actually what intensifies them. The very effort that the individual uses, the energy that they put out to try to ignore and stop thinking about them or to make the distress goes away, actually increases the likelihood that it will become stuck, which is kind of a paradox and something that most people don't necessarily know, right, off the top of their head. An individual may not realize that they're actually reinforcing their intrusive thoughts and their rituals, but then they get to a point where they're happening so often and their distress is so intense that they come to therapy. And that's when we start to talk about some of these patterns and use this information to help set the stage for what we're going to do in treatment, because it is understanding this process and this cycle that contributes to the client's buy-in to participate in ERP, because they're able to understand what's happening and it seems logical to engage in the treatment. And so that we'll talk about in a little bit too. So now I want to just take a pause because I've been throwing a lot of information at all of you, and I want to share a quote. So between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. This is a quote by Viktor Frankl. I think, and I find this quote to pair beautifully with what we're talking about with OCD and ERP, because in that space, which is the space that we work in therapy, is helping the client determine which response they want to have to the stimulus, which their intrusive thoughts or images. And when they're able to choose their response, really choose it, not feel like they have to engage in the compulsion or else, they experience growth and they experience freedom. And I've had clients describe their experience with ERP in very much that way. I had a client share with me that being able to change their response really helped their world that had become so small become so much larger and open again, and that it was so freeing to not have to respond to their obsessions with a ritual. And so our goal in treatment is to help the individual change their relationship with their thoughts and images, not to combat thoughts, not to replace the thoughts, but to allow them to be there and to experience them in a different way. Because when unwanted thoughts and images aren't perceived as distressing and they don't feel dangerous, they stop bothering us. And so when they don't bother us, we feel the need to engage in a ritual less. And so part of this process, a really important component of this is developing an attitude of acceptance towards the thoughts and images and urges, because that also paves the way to being able to choose a response. And so that is my segue to talking to you all about ERP. So what is ERP? It is a specialized type of cognitive behavioral therapy that is designed to assist clients in achieving symptom relief without resorting to engaging in avoidance or rituals. And again, we know that the effort, we've talked about this, that the effort to avoid, suppress, and engage in the rituals hasn't been helpful, because long-term, they're still experiencing distress. if the avoidance had worked, then the very next time the individual had a thought of dropping their child, there would be no distress. But that's not what happens, because the relief from the ritual is short term. So this ERP offers a long-term solution. And so there are two components. And so our first component is exposures. And it's in this process, the individual, the client, is invited to confront objects or situations that are known to produce distress. And then they are invited to stay in the presence of that situation or object for as long as it takes for the distress to decrease on its own. And it is a key ingredient for an exposure to be facilitated appropriately, is that the individual welcomes the distress and invites the distress and directs their attention to the distress during the exposure. Because it is when the information is confronted, and it's when the individual is facing their feared consequence, that we're able to change their response. And they're able to then learn that their feared consequences don't occur. Then we have response prevention. So much like it sounds, response prevention requires the client to stop ritualizing, even when they may be experiencing urges to do so. And there's a couple of different ways to handle response prevention. So there are times where response prevention is, it's really an all or nothing. So we go from all hand washing to no hand washing, or we go from all checking to no checking. And that's, again, response prevention. They're not able to ritualize. Oftentimes, what I find to be helpful is working towards a gradual decrease in ritualizing. And so during this process, during treatment, I have individuals document and record the situations in which they experience intrusive thoughts, the compulsion that they wanted to engage in. And then I have them document how many times over the last week they were able to resist the urge to ritualize. And what we hope to see is that that decreases gradually over time. And again, a lot of that happens in tandem. So as the individual resists the urge to ritualize, the power of the intrusive thought goes down. And as the frequency and intensity of the distress goes down, the client feels less of a need to engage in the rituals. And so it does work in a kind of bi-directional way a lot of the time. So then what happens next? The client comes to therapy and we work together to identify their themes, their obsession themes, and what their feared consequences are. And through this process, we identify their specific cues, both external and internal, that trigger their distress. So for the client that we talked about who may be playing with her little sister and experiences thoughts about potentially being sexually attracted to her, we've talked about it in session, and she's able to say that whenever I am asked to give my sister a bath, that's a trigger, and that's when I experience distress. Or whenever I walk past my sister in the living room, that is a trigger to experiencing distress. We kind of go through their specific obsessions and identify the triggers, and then we work together to plan exposures that can be conducted in and out of session. So there are two types of exposures that we work with: are in vivo exposures, which involve confronting the feared objects and situations in real life, and then imaginal exposures, which we use for those situations that can't be facilitated in real life or in session. And so instead of the real life situation, the client creates a detailed and vivid sequence of images or story depicting the disaster that they believe will occur if they do not ritualize or avoid. And so oftentimes I work with clients to prepare that in session. We may do this through writing it down. They may talk through their situation or their feared consequence, and they might record it and then listen to the recording later. I'm pretty flexible on how the client wants to go about doing that. And so then we start figuring out what exposures we can do. And we talk about how we want to implement them. So there are a couple of different options here too. We may work through a gradual exposure where the individual might first imagine their feared consequence, and then they may confront it later on. Or we may just jump right into the most distressing exposure and approach it all at once. So there's variation here. And so I'll just give you an example of each. So for an in vivo exposure that I did with a client who had contamination concerns regarding chemicals and household products, very much avoided changing batteries in household products, in the remote, in kids' toys. And so what we did for an in vivo exposure was we had the client hold batteries from a household object, not new batteries, but take them out of an item and sit while holding the batteries and invite them to confront their feared consequences, to think about and to bring to the forefront of their mind what they believe may occur as a result of touching these batteries. And then for an imaginal exposure example, I had a client whose obsessions were related to their relationship, which is one that we didn't talk about earlier, but they had a fear or worry about their partner not really loving them and not really caring about them, and so potentially being unfaithful. So in this imaginal exposure, we had the client create a recording of a story where they experienced and observed their current partner being unfaithful and telling them that they didn't love them. And so then the client was invited to listen to this recording on a daily basis for their exposure. So this is what we do. Why does it work? The model for explaining the therapeutic effects of ERP is referred to as an inhibitory learning model. And in this model, we're really talking about the opposite of conditioning. So an individual, if we're looking at this graph right here, this is their anxiety level, and this is the amount of time that they may be engaging in their ritual. So if we're using a contaminated example, an individual who has a fear of touching batteries is confronted with batteries, and their anxiety starts to increase. And maybe we'll say that their anxiety at this point has reached a 5 out of 10. At that point, they determine that they cannot cope with the distress any longer, so they engage in a ritual. And then their anxiety immediately reduces, but not for long, because the very next time they think about or face batteries, their anxiety goes up again, and they engage in a ritual, and it immediately drops. What we're doing with ERP is allowing the client to feel that contaminated feeling, to experience that distress past the point of 5, past the point of 6 and 7 and 8, maybe even reaching 10 during the exposure, because we expect that their anxiety will increase because they're not ritualizing. But over time, they learn that their anxiety will decrease on its own. They learn that by actually sitting with their anxiety, in session, the longest I've experienced so far is about 45 minutes. So the individual, they sit with the batteries, their anxiety starts to increase, and maybe it reaches that peak at about 20 minutes or 30 minutes. But because they haven't ritualized, they sit with it. And eventually, after sitting with it, by minute 40, 45, they were able to say that they feel calm and that they're not as worried and that they're not as anxious. And so by doing this process repeatedly, we're increasing the client's tolerance for distress. We're showing them that they can experience distress without ritualizing, and that even when doing so, their distress goes away. We show them in this example with the client who held their batteries that the feared consequences do not occur, and that the distress doesn't last forever. And so over time, we're able to change the way we respond to the same intrusive thought, because we're now unpairing the distress and the fear from the thought. So what does it require to be able to implement ERP? I often refer to the ingredients for success, because we really do have certain ingredients that help contribute to the success of treatment. And so first one is a willingness to tolerate distress in the short term to benefit in the long term. And just like that graph showed at the beginning, when the client isn't able to ritualize right away, they're going to experience an increase in their distress, but maybe a level of distress that they really aren't familiar with because they've always ritualized. And so by explaining some of the concepts that I've shared with you today, we help the client understand the benefit and the reason for enduring that distress. And then we also want to make sure that they are willing and committed to set aside time to practice exposure and response prevention between sessions. So depending on the client, you may have a client practice an exposure twice a day, 4 times a day, every other day. Regardless, all of that requires time. And so we want to make sure that they're willing to give that time. And then another point is that the goal is to conquer and eliminate the compulsive behaviors entirely. And I put that there, and I share this with clients because I want them to understand, and we want them to understand, that even engaging in the compulsion just once reinforces and can start the cycle all over again. And it's not, like we said, it's not always immediate. And once we've gotten to the place where we are resisting the urge to engage in the compulsions entirely, we want to keep that up so that we don't start the cycle all over again. And then oftentimes, I invite the clients to identify a support figure, a significant other, a friend, a parent, to help them through this process. Because when they're at home practicing the exposures and they're experiencing distress and they really feel a strong urge to ritualize, it can be hard to experience that alone. And it can be scary, and it can be comforting to have somebody sit with you and help you create space to endure the distress while resisting the urge to ritualize. And so I've found that clients that I've worked with have really enjoyed inviting somebody to sit with them while they're resisting the urge. And now I want to make a quick little jump over to acceptance and commitment therapy, because this is another therapeutic approach to addressing ERP that is also evidence-based and has been proven very effective. Acceptance and commitment therapy, if we think about it, and for those of you who are familiar with it, this may make a whole lot of sense. There's a lot of overlap between ACT and ERP in that ACT invites the client to actively contact physiological experiences directly, fully, and without needless defense. So that is the acceptance piece. And we might parallel that acceptance piece to an exposure, because during an exposure, we are doing exactly that. We are having the client contact their physiological experiences directly and fully and without any needless defense. What is powerful about ACT is that it takes ERP one step further. Rather than just helping the client tolerate the distress, ACT gives us a way to invite the client to take steps towards living a life that is full of purpose. We don't just tolerate the fact that we're having this intrusive thought and we can acknowledge that it's there and we don't engage in the ritual. Now what? When I'm really motivated to spend time with my sister, and that's one of my values, I now am taking it one step further. And so I'm tolerating that I'm having this intrusive thought that may be sexual in nature or harmful in nature. And I am still choosing to spend time with her because that is one of my values, and that will help me feel that I'm living a life full of purpose. So I wanted to give a short little plug. I use both ACT and ERP in my work with OCD. And so I want you all to know that that is another viable and effective option for treatment. And then my last point for today is just a little note on medication. Again, as a clinical psychologist, medication isn't my area of expertise. However, I do educate myself and stay informed on what medication has been approved for OCD and what some of the impact is of medication on ERP and OCD treatment. So there are several SSRIs that have been approved by the FDA for OCD treatment. And one one tidbit that I would like to highlight is that when an individual comes to treatment for OCD, oftentimes, I'm not sure the statistic, I didn't write it down, but oftentimes the individual is already taking medication. And so what research has found is that adding ERP or initiating ERP after an individual is already taking medication actually serves to increase the efficacy of the medication. So I think that's very interesting and a powerful fact. And then another fact that I want to bring your attention to is the note here at the bottom that if medication is being used as a treatment on its own, research has shown that there is a dramatic rate of relapse if the medication is discontinued abruptly without any other treatment. So if that is going to be the sole method that the individual is going to be using is medication, we want to encourage them to stay on that medication or talk with their prescriber about discontinuing and help them prepare for what might occur after they stop the medication, because we've seen that contributes to relapse. So again, just my short little blip on medication. And then what I have for you on the next couple of slides is clinical application. And so I just put some examples up there for you all to look at of a self-monitoring log. I've shared an exposure hierarchy for you guys to look at and reference. And I've also shared some examples of ritual prevention guidelines and what that looks like in working with clients. So that is all I have for you today. And I will, I totally forgot, I have some resources for you. These are resources that have been really helpful for me, and both for professionals and for individuals with OCD. So those are some resources. And then I will leave you with my contact information and turn it back over to Jordan.
Wonderful. Well, thank you so much for such a great and informative presentation. Oh, sorry, let me pop my thing on there. All righty, perfect. So yes, we do have some great questions. Some of these have come in here, some near the start of it. And again, so you've probably answered some of these in at least some context or another, but maybe just as a summation. I'm just going to go through as many as we can here. We have about a remaining 10 minutes. Sure. Wonderful comments in here, a lot of thank yous, a lot of wonderful presentation, wonderful information. So first question we have from Frank. I have, and I feel like a lot of people have probably thought this before. I always have to run numbers in my head, counting, adding, figuring, problem solving. And you talked about that a little bit from like the intake perspective, I remember. But you know, what would be considering with those types of behaviors as far as like OCD?
Can you read that to me one more time?
Yeah. So, you know, having to run numbers in your head, counting, adding, figuring, problem solving, would that be considered as qualifying as OCD? And if it's obsessing over things, projects, crafts, perfectionists, things like that.
So I think, and again, I can't give a diagnosis here over the presentation. So one thing that popped into my head that I would invite the individual to think about or to consider is the motivation behind the behavior. And again, when we find that individuals engage in behaviors that are motivated to reduce distress, that are in response to a specific feared outcome, that is usually how I distinguish between a compulsion / ritual versus generalized anxiety and worry about a variety of things in life and working to problem solve those. So that is one distinction that I might use. And I definitely invite that individual to consider to reaching out to a professional, a therapist, and maybe exploring that a little bit further and examining their specific instances. Another point there is that we do see a lot of overlap. So an individual may have OCD and may also have generalized anxiety, which is not uncommon.
Great. Yeah. And I feel like a lot of people, right, they'll have those tendencies and they'll say, oh, you know, did I forget to put down the garage door, right? Things like that. And it's always interesting to see how those things pop up. So everyone wonders then, oh, well, do I have OCD? Do I have tendencies? Right. So.
Yes. Great point. And again, that thought in and of itself is probably common. I mean, I have done that myself. Oh, did I put the garage door down? The difference there may be is that the degree of distress that I experience and the degree of fear. Am I saying, okay, I'm going to go solve that, I'm going to go check one time? Or is my feared outcome, if the garage door isn't closed, XYZ terrible thing is going to happen?
Right. Okay. So that's where the large distinction would be then. That's huge.
Yeah.
All right. From Amanda, we have, how do you suggest managing comorbid OCD and eating disorders? Do you have any info or insight that would be helpful in terms of that?
That's a very interesting question. I think that I don't know that I can speak to that because I don't have expertise in managing eating disorders, and I would be apprehensive to share or to reflect on that without having specific knowledge in that area.
That makes sense.
Because I know eating disorder treatment is very specific.
Very much.
Yeah, I wouldn't want to say. Yeah.
Now, this could be kind of in the same vein, but does the OCD spectrum include addictive behaviors or addictive personality traits?
So it's interesting. I would say that there may be similar mechanisms at play and similar features. I would still probably venture to say that they're different diagnoses. So for example, when I'm working with clients and we're talking about ritual prevention, I may reference this idea of not being able to engage in a ritual even once, similar to an individual who's working on addiction. Their goal may be to completely abstain from consuming alcohol, for example. And so in that, there may be similarities in the way we're thinking about it and the way we're encouraging the client to refrain from engaging in those rituals or in those behaviors. And I see them as distinct diagnoses.
Wonderful. Well, thanks for answering that. Now, this next one, it's kind of a two-parter because we had someone else that asked something that I think relates to it a little bit. But this one said, kind of how much damage or what damage could potentially be done through OCD behaviors to perhaps like an unborn child, right? For someone who's, is pregnant, who is doing different ritualistic behaviors. And then I think the other kind of second part of that question is there was a question just looking at genetic framework. And so kind of cause of OCD, are there genetic markers for that? Is that something that are inherited traits, or is that something that's more of a learned behavior?
Yes. So I'll answer that part first. Definitely what we understand is that there's both an environmental and a genetic component. So we do see, we do understand that there's increased likelihood in family members, and we do recognize that an individual may be predisposed or have a higher likelihood of developing OCD because of their biology and genetics. And then we see environment also having a really big role. And so again, there's so much more that I could have shared today. So if we're talking about, for example, experiencing a natural disaster, that might be a trigger that initiates somebody's experience of OCD, or somebody experiencing a significant trauma, or even exposure to the news. All of those are environmental influences that have been researched and have been determined to influence or kind of kick off an experience of intrusive thoughts. And then if we experience those thoughts as distressing and engage in rituals, that can be the domino. So it really is both. Regarding the question of a harm to an unborn child, I think I might need a little bit more clarification on what that means.
It's a little vague, to be honest. And so that's where I wonder if it's like environmental things you're doing could cause harm in some way. But I don't know as far as like a thought process, right? If that gets passed along.
So if we're taking if we're thinking about an individual with OCD who experiences overwhelm with contamination, that individual, and research has shown that individuals with OCD, specifically with contamination, may avoid going to certain places in their environment. So if that individual who's pregnant is avoiding going to the doctor's office because the doctor's office seems like a really scary place that would trigger their worries, that may have consequences. If that individual, right, I think it depends on the specific rituals. And And what that, I mean, maybe that might look like impacting family support. Maybe the individual has intrusive thoughts about harming family members or harming friends. And so as a result of that, they withdraw and avoid. And so they no longer have social support. And so they're feeling isolated, and that impacts their kind of their mood and their mental state. And so those are just a variety of ways that the rituals may impact a woman who's pregnant.
No, that makes sense. And kind of a few different layers there. Well, we only have time for a couple more. What about, so can ERP be used in conjunction with hypnotherapy to achieve positive results?
I have no experience with hypnotherapy, unfortunately. I'm sorry.
All righty. Well, hey, it's a great question.
Great question.
Yeah. Does exposure therapy work best in person, or can it work via telehealth?
Great question. In my experience, it has definitely worked well with both. And especially during COVID, when many providers were only providing treatment through telehealth. And again, a lot of the training and seminars and conferences that I participated in talked a lot about this. It is very possible to effectively administer ERP. There's some maybe additional conversations that can be had to navigate that. And we want to, sometimes that might involve having the client move their camera or showing you different, places or parts of their home so that you can really see. And if they're motivated and there's trust and rapport, it is absolutely possible. A lot of times I even encourage it if the specific exposure is in the individual's environment or at home. Mm-hmm. I might say, okay, next week, we're going to do this exposure. We're going to do it, at our usual time at 12 o'clock, but on telehealth. So you can walk past the gun safe at home that is currently being avoided because it triggers thoughts of harming others. So it definitely can be done on telehealth and in person.
Wonderful. Well, with that, we are just about here at time at 1:30. So again, I know we didn't get to every single question that's there. If you'd like to, please take a quick moment and get Dr. Rozio's contact information on there. Love to have you reach out. I know a few folks had reached out just wondering about services you provide. So again, please feel free to reach out. And with that, we just want to thank you all for joining us today. What I'd like to kind of end today with is we will go ahead and leave up just a quick QR code. So if we can do a stop share over there. Sure. And what I really just wanted to share with you all is that, we really appreciate, I'm going to do just one last single person round of applause here, but we still have 300 something of us here for your presentation today. Thank you so much for joining us.
Thank you.